Well, he's not answering, but I see the recording icon, and he also told me he's going to record, so I think it's going to be okay.
Okay, that's fine.
Just a very brief introduction. My name is Lior, and I'm the tutor of the students in Pinit Bet. And we have Roy Tsukil with us, who took the time and effort to wake up very early in New York to give us this lecture. So please be attentive, and I'm sure we're all gonna learn a lot from him. So passing it on to you, Roy. Thank you.
Thank you, Lior. So hi, everyone. My name is Roy or Roy or whatever. And I'm currently at Mount Sinai in New York. And when Lior asked me to do this presentation about LGBT medicine, I thought it will be for me also a good reason to finally kind of construct a new LGBT medicine presentation also later on here for Sinai. So thank you for that, Lior. And I'll tell you a bit about myself. So I'm an internal medicine and infectious diseases physician. I like I did internal medicine, and I was trained in Beilinson Hospital, and then I moved to Ichilov, actually, there where I did my infectious diseases. I finished in January last year. And since then, my next job actually was exactly just after the COVID-19 started in Israel. So I was the medical director of the COVID call center in Magen David Adom in the ambulance services of Israel. And this is what I did during the first wave. And now at Mount Sinai, I'm practically, so it's a kind of like a long story, but if we make it short, I'm practically the first who is doing LGBT medicine fellowship at Mount Sinai. So I'm the first in this program, and it's going to continue later on by the American College of Physicians. It all started when I was here 1 year ago, just while I was doing my infectious diseases, more than 1 year ago. It was actually almost 2 years ago. And I did just my HIV practice, and then it came to the point that I met the president of Mount Sinai. His name is David Rich. He is a gay man, very into the transgender program here. This is kind of his baby. And then we spoke about like, why not making this new program, which is all about LGBT medicine and the different disciplines of LGBT medicine, put them all together in a 1 year program. And since then, it just like, moved on. And actually the Tel Aviv Medical Center, Ichilov, actually helped me make it happen also. So with the help, and there is a nice cooperation between actually Mount Sinai and the Tel Aviv Medical Center, and we made it happen. And now practically there are 2 programs all over the world. Both of them are in the US, one of them here at Sinai, and the other one is in UCLA, where they started it also 2 years ago. And actually today it's kind of like, the presentation is very long, like I don't wanna, we won't have time to talk about everything because it's practically a lot. But I want it to be kind of like more of a discussion, and towards, we'll see how it goes, and you will be my guinea pig for this presentation and how it works. So let's start. Any questions so far? Great. So what are we going to talk about? So practically, if we'll have enough time, we're going to talk about like, what is LGBT medicine? Why do you need it? And this is kind of a question that I get a lot, like, why do you need to have a specific discipline for the LGBT community? Isn't it that everyone needs to know about LGBT medicine in the medical profession? So why isn't it like, sometimes I get a question is like, doesn't it make it more kind of like a stigma if they, if the LGBT community do need a specific kind of medicine? So I hope at the end of this lecture, I'm gonna kind of convince you why it's a totally different discipline, which is actually integrating a lot of other disciplines all together. And we will dig a bit. So there are so many subjects to talk about, but I will dig a bit about like specific issues and stuff that I did also like in Israel when I was back in Israel. I didn't say that, but in the last 3.5 or 4 years, actually, I'm a partner in the LGBT clinic in Tel Aviv, in Gan Meir Clinic, which is the first LGBT small clinic in Tel Aviv that started 10 years ago, and now we have like more than 2,000 people. And like a lot of them are most of them are from the LGBT community, but sometimes we always like to say that we are hetero-friendly also. So let's talk about a bit about the real facts. And the facts that are true for the US are actually true for Israel also. And having said that, the LGBT community is always experiencing, and it's true also for the last few years, disparities in social stigma and discrimination and denial of, you know, civil and human rights. And we can see it also like in all kind of subjects in Israel, but it's a big thing also here. Saying that, you know, when you live in New York and even in Tel Aviv, you might feel that, wow, everything is fine. I don't understand. What's the problem? It's like you know, everyone gets the same. It's kind of the same. But actually, you know, the real world is not New York and it's not Tel Aviv, but it's the other places and you know, either suburban places or rural places that it is a big issue still. And we have to understand that. So there was a lot of research done about the accessing to healthcare by people from the LGBT community or LGBTQIA, or, you know, there are so many words like letters after that. So I'm usually just saying LGBT plus or LGBT, but, you know, it's for others also. And accessing to care and to healthcare is a big and major issue for LGBT people, mainly because a lot of them do not want to disclose themselves, or they feel that if they will go to their primary care provider, they will kind of feel that they are not being accepted, or they are kind of like having a problem of, you know, disclosing their lifestyle or what they are doing in their life. So this is kind of a major issue. And it is directly leads to the place where those people are actually avoiding or delaying care and not receiving appropriate care, not even talking about prevention measures or prevention medicine, which is kind of a problem in the community. So we are always talking about, like, you know, this is like a very important issue. So people, sometimes we see them just in the extremes when they really have to go and eventually they end up in the hospital or something like that. This is true for HIV, for STIs, and a lot of other subjects like drug addiction and all kind of things. Again, eventually this will lead to a poorer health, and those issues needs to be addressed. And practically, this is what LGBT medicine is all about, but not just. So when we are talking about LGBT medicine and who are the people who are supposed to actually take part in LGBT medicine, it's not just about doing medicine. It is being the source of knowledge for other issues also, the issues that are relevant for the LGBT community, and we will talk about them soon. But it's also about leadership. It's also about being the ambassador of those people who are not being like, they don't have the access to care like they should have, and kind of leading a new profession or a new, you know, topic, which is all about LGBT medicine, and also teaching people who are not LGBT medicine specialists, but just want to know more. Exactly like what we are doing now, actually. And of course, I see this, you know, this profession also, it cannot go hand with hand on community involvement, because community involvement is a big, big issue. And this is the way to actually approach a lot of LGBT people who are not getting the healthcare they need. And we'll talk about all kind of community measures that I and my friends did in the last few years in Tel Aviv also. By the way, just a minute, let me see. So I know that it might be like very bothering, but I really hate looking at, you know, just names. So if most of you at least can open their camera, that would be great, okay? Especially because this is kind of a discussion eventually, and I feel like, you know, I'm taking some Zoom calls my own, and I know what's going on, and I know that it's, you know, sometimes embarrassing or something like that. So if someone is really against it, no problem, but I really prefer that your cameras will be on and that you will actually, this is kind of like part of being participant, okay?
I just wanted to let you know that some of our cameras aren't working, so that's just why they're off, but we're with you.
That's fine. Again, I just said it, and from now on, it's all yours. So when we are talking about what is being an LGBT physician or LGBT as a profession, we are actually talking about this physician who knows every kind of details which are relevant for the LGBT community, but in the different disciplines. Meaning infectious diseases, like of course, like HIV, STIs, vaccinations, and much more. Endocrinology in the side of transgender medicine, and mainly urogynecology also in the transgender medicine part. Addiction medicine, which is a very, very important issue in the LGBT community. Geriatrics. So when we are talking about geriatrics and adolescence medicine, this is also a very important topic in the LGBT community. We see the LGBT community is getting like older and older, and especially now when we see a lot of people who are living with HIV, and we say today, this is why we say living with HIV and not HIV carriers anymore, because people are living with HIV and they are living quite well with HIV. And a lot of people I see here in the clinic, people who have those stories and they got their HIV, they got infected when they were, you know, at the middle of the 80s or the beginning of the 90s, and they are living their life now. And we are seeing this aging population, and this is like a very important issue to address too, because they have sometimes they have much more, you know, comorbidities, either because of the, you know, the regimens that they took back then that have all kind of consequences, but also just because they're of their HIV. So all of those together is exactly what I'm doing actually in my fellowship. So every Monday I'm learning how to do anoscopies and all the area of HPV for gay men. Every Tuesday I'm doing my transgender medicine day. Every Wednesday I'm doing LGBT psychiatry and mental health. Which I didn't talk about now, but this is like a major issue and a very important one. Every Thursday, I'm, you know, having my HIV and STI clinics, and every Friday I'm doing like addiction medicine. And while I'm doing that, I'm also doing my master's here in LGBT, like, sorry, not LGBT, but master's in healthcare delivery leadership. But I'm doing it also in the side of like being, you know, taking it to the LGBT kind of orientation. So all of those things are exactly what this fellowship is all about. Just taking 1 year and make someone who has the, you know, either internal medicine or family medicine background, and make him much more familiar with the LGBT area. So I always I thought about how to start it, and I thought about it, and it's a great, so I don't know those people. It's just like I took them, I think they were in Survivors or something like that. But for just for this manner, I will use them just to tell you what it is all about. So Dan and Tom are, you know, they are a gay couple. They are together, they are married, they are together for like 4 years now, let's say. And you know, they have their issues, and this is kind of like a thing that we see a lot during the time. So, you know, there are a lot of people in the LGBT community are in open relationships. So they are having, you know, sex with other people also, sometimes together, sometimes not. They are involved, like, and all of those, a lot of those things that I'm going to talk about are actually, we are going to elaborate on them later on. So once in a while they do go to parties, and they are taking part in a thing called camp sex or PMP, party and play, which we will talk about a bit later on. but this is all about like, drug use as a, as part of like doing or having sex. They are discordant couple. Do you know what is discordant couple, by the way? No, no one knows?
I am queer and I do not know.
Sorry, again?
I said I'm queer and don't know.
Okay, so discordant couples are, one is HIV positive and the other is negative, okay? So one of them, let's say Tom is living with HIV and Dan is not, okay? And when they met, they just knew about it, and I'm just telling it because this will be an important issue also for for our talk. They are starting like looking for, I was very surprised to see that in New York, at least it's not like super common, but in Israel it is for sure. It's still in New York, it's also, but not as it is in Israel. So they are thinking about having like surrogacy and they want to have children. Okay, so this is another issue. Now, Tom lately is suffering from depression, and as part of that, or not as part of that, is having also issues of sexual dysfunction, usually with Dan and with others when he is kind of like, trying to make things work. While Dan is also into, gym and stuff, so he's like very into, gym enhancement stuff and anabolic steroids and stuff. So he's using some of them and things like Anavar or other steroids and stuff and testosterone, while just lately had an infection in Mycoplasma genitalium. So whatever I'm telling you here, this sounds like, okay, so I took a lot of things and just put them all together, but this is happening a lot. And what I'm showing you here is practically almost a very common couple who is entering our clinic either at Sinai, but also lately also in Tel Aviv. So all those issues needs to be addressed. And the problem is that sometimes, if you just go to a family physician and tell all about that, they will kind of like say, okay, I don't know a lot about that. So, okay, you have a sexual dysfunction, let's send you to urology. If you have your depression, let's send you to psychiatry. If you have issues with chemsex and stuff, so again, let's talk about like, I'll send you somewhere to addiction medicine stuff, and et cetera, et cetera. So again, the thing is that it shouldn't be like that, and it shouldn't be so complicated, because all of these issues can be addressed just by someone who got trained to do it all, or with orientation to the LGBT issues. Now, I don't know if did anyone see Pose? It's a great show.
Sorry, I just have a question.
Yeah.
Would you mind walking through the sort of female or lesbian version of the previous slide? Just because I think the gay male community gets much more sort of attention and visibility.
Exactly. So as you can see, we didn't finish yet, and it's there. So just wait a bit. Yeah, but we will talk about it also, because you're right. Like for lesbian women, it's very important also like addressing specific issues. I do have to say that mostly it's in the part of prevention. There are a lot of issues regarding like gay men stuff or gay men health, but lesbian women do have a lot of like discrepancies in healthcare, and we'll talk about it also. And I took the other extreme. So I took another extreme, which is, so this is like the main actor from Pose. Pose is all about, is a nice TV series that was, out 2 years ago, I think. There are like 2 seasons now, and it is a great one. I would really suggest you to see it. But this is, for example, Electra, and she is a transgender woman, okay? And she has her issues, also. So while she is a transgender woman, she also got infected in HIV in 2015. She had, or she still have math issues and crystal meth using issues. We see here a lot in New York, by the way, and this is something I wasn't so familiar with and how big it is, the issue of bipolar disease. So we also see that she suffers from bipolar disease and she's being treated for that. Also lately, she had a abnormal pap smear, an anal pap smear, and we'll talk about it also in the gay men orientation. And she's of course on hormone therapy, and now just like lately she's thinking about, you know, starting having her surgeries also. So a lot of issues to be addressed. And again, so we can, you know, HIV can be treated by one physician, by infectious disease physician or whatever. The hormone therapy can be treated by someone else, the bipolar disease by the psychiatrist, etc., etc. But what we are trying to do is kind of like combine them all together and just use, you know, the psychiatry, the endocrinology, and the HIV as, you know, in just extreme measures, and not just like, you know, coming there every 3 months to do kind of the same. And of course, fertility issues, which is an issue, and sometimes we have to think about it right before we start the hormone therapy, because that might affect the fertility of either transgender women or transgender men. So what are the main topics that we are talking about? It's mainly so primary care, of course, for men who have sex with men, for women who have sex with women, transgender care, all the areas of hepatitis B and hepatitis C, which are also like might be specific for the LGBT community, you know, in one part, because the way they are, we can get them. So HIV treatment, high resolution anoscopy, which is a thing that I'm studying doing here, but in Israel it almost doesn't happen at all. And the pap smear for men, for example, is something that we don't do in Israel, and this is kind of a debatable thing. So we might, if we'll have time, talk about that. Of course, mental health and you know, and other issues like adolescence medicine, geriatrics, and whatever I said before. So if we go by the letters, and then I'll answer your question about lesbian women also. So there you go. We are starting with lesbian women. So one of the major things we see in lesbian women is actually all the area of prevention, and we see it as a major issue. We see much more breast cancer, for example, in lesbian women, just because they are coming less, you know, to do the screening with mammographies or later on ultrasounds. Same with cervical cancer. They are doing much less pap smears, and this is like I'm telling you in numbers which are tens of percents, like 40% less, 50% less, also in Israel. And in breast cancer, for example, there were studies that also were showing that for lesbian women, it's like more than 3 times, they have 3 times more the, you know, the incidence of having or the odds of having a breast cancer, for example. We see also the area of smoking, obesity, and fitness issues also in lesbian women, much more, and that should be addressed also. And we do see that lesbian women are coming less to the clinics. They are using healthcare system much less. And substance abuse and smoking, this is an issue also. I talked about smoking also, and of course, together with everything, it's kind of wrap it up to worse health. And eventually, this is something that I feel also here in my fellowship and in the clinic that is not being addressed enough. You know, this is one of the big black holes of LGBT, even places that are very LGBT oriented, they are still not doing such a good job regarding lesbian women medicine, let's say. Another issue which you might not be familiar with is all the area of bisexual men or women. And this is kind of like a big issue just because, you know, the people who are bisexual are actually, they don't feel belong to any place. So they don't really want to you know, identify themselves as gay or lesbian, and they shouldn't because they are not. And they are not really feeling that they are part of the heterosexual world. And for them, it's even worse because if you think about it, when they don't, sometimes they don't want to go to an LGBT medicine, like LGBT oriented place, because they don't identify themselves as part of it, or they don't want to be considered kind of like as a gay or lesbian. On the other hand, also like if they just go to their primary care, they also don't get they are not disclosing themselves. And this is like, there were really nice studies about it. Some of them were just lately that show that their situation is even much worse than lesbian women, than gay men, and even less than, like much worse than transgender women and men. And they are kind of caught in the middle, so to say. And this is like something we should really take care of also. And they have much more, you know, the incidence of, like, if they have HIV, it's more likely that they won't get treatment as good as a gay man, for example. And also like in the area of substance use and mental health and suicide. In suicide, it's almost like in transgender people, which is, the numbers are crazy. So so this is an important issue to address also. So we walked through a bit about transgender and gay men. And again, like if we talk about it, so
may I ask something?
Totally, yeah.
Would you say closeted men have similar problems to bisexual that you just mentioned?
Yeah, totally. So closeted men, I put them, you know, it depends if it's a closeted lesbian woman or a gay man or bisexual. You know, being closeted, it's not the it's not like the issue is that you get less of a care just because you don't want to disclose yourself, and it doesn't matter if you are lesbian, a gay man, or transgender or bisexual. So of course, this is like apply for all. Now, another questions before I'm continuing? Great. So what I'm going to do, actually, you know, there are so many things we can talk about, but I just wanted to talk about the things that, you know, we are doing right now, things we did in the past, and maybe talk a bit about the future. So I wanted to address a very specific issues, which are kind of like the hot issues in LGBT medicine nowadays. And of course, there are much more, but we can't have it all in such a short presentation. But yeah, mainly we'll talk about like STIs and like sexually transmitted infections in the gay community and in the LGBT community generally. PrEP, where I hope that most of you at least know what it is. Mental health, harm reduction, and stuff. So one of the things I did the most in Israel, and this was kind of my hobby, was actually talking about harm reduction in the LGBT community regarding drug use. And this is kind of a thing that when I started like working in the field, I really felt that there aren't those physicians who you can come to and say, okay, I'm doing drugs, and what can I do about it? Because most of the physicians would usually say, or the providers would usually say, okay, why are you doing it? Just don't do it, and that's it. There wouldn't be any guidance for, if you are doing it, let's do a harm reduction, you know, program and talk about, if you do it, how to do it right. Or I'm saying, do not use drugs. That's not a good thing, but if you do, let's guide you through how to do it, you know, relatively on the best way you can do it. And this is part of, you know, all the area of harm reduction is kind of like a very important issue. And we see a very specific issue in the LGBT community is a thing called chemsex. And what is chemsex? Someone heard about it?
Yeah.
Can you tell me what you know?
Oh, it's just using drugs. Okay, yeah. thanks. It's just using drugs to sort of help heighten your sexual experience. So like on your app, you can put PNP, and that just means party and play. And then people will know kind of going into that you want to combine the two. Also, oftentimes in like gay clubs or parties, there's a lot of sort of drugs going around, and that's kind of pretty normalized.
Right. So chemsex, thank you. That was great. So chemsex is actually less of a talking about party drugs like MDMA, ecstasy, even LSD or acid or those kind of things, but it concentrates on the specific drugs or are actually part of like having a kind of a sexual enhancement. And usually this is being done actually not as part of a party, but a home party, let's say. We always call it in the gay community, we call it chills. It's kind of some people, usually like a small group of people who are gathered all together. And sometimes the big problem we see with chemsex, it's not about the sex, but it's also like mostly about the drugs and having sex while being on those specific kind of drugs. And this is kind of like a lot of those people who are actually, practice chemsex are actually finding themselves at some point in the mental health issues, they cannot enjoy sometimes sex anymore just because they are so used to having this sex with, this very big high of being on specific drugs. Now, there are only three kind of drugs, which are kind of like oriented with chemsex. And those are GHB, crystal meth, and mephedrone. And each one of them is I can talk about each one of them for an hour. But you should know that in Israel, at least, and in the US, because mephedrone is more in the UK, actually, we mostly use GHB and crystal meth. And one of the biggest problems in Israel also, it started like 3 years ago, and this is one of my biggest battles when I was in Israel, and now in New York, I can see it also, and how big of an issue is it. It's the crystal meth use. And crystal meth, I always say, I'm willing to talk about a lot of things regarding harm reduction, how to do things right. But with crystal meth, this is kind of like the red line, which usually you shouldn't cross, because this is a super addictive drug. It's actually, people likes it because like if you hear about someone who actually telling you the first experience from crystal meth, it sounds amazing, really. Like those people can stay awake for 36 or 48 hours, having sex all the time, being very, very, sexually alerted, but the thing is that crystal meth really changes you. And some people have even say that after first use, you can get addicted. It's actually 3 times more addicting than cocaine. And it's actually working, the levels of dopamine that you get from crystal meth use, there is no other drug like that. And I was thinking about showing you actually, let's try to do that. This is a movie that was being done by, I think, National Geographic. So I'll try to share it, and it will be just 3 minutes of telling you a bit about crystal meth and just a minute, let's see. So I think I need to kind of do that. And then stop sharing.
גבוהה במסיבות הסקס של הקהילה ההומוסקסואלית בעולם, ולאחרונה גם בישראל. טינה נותן את ההרגשה שזה משהו קליל כזה, חמוד, כמו שלרטלין קוראים ריטה, ל-GHB קוראים ג'ינה.
You can't hear anything, or can you hear something, or is it? We
can only hear but not see.
Okay, I'll try to put something in English actually, because this is the. Let me see. So where did I put that? I think it would be. Just a minute. We'll give it 1 minute, and if it won't work, so we'll skip it. Maybe it was that. Yeah, so I'm going to put it now, and I'm going to share the screen again.
This was a drug that I had never seen the likes of before. I was able to stop cocaine.
Do you see it now? Do you see a YouTube thing?
Yes.
Yeah.
Okay, great. So I'm putting it. Just tell me if it's not working. I hope it will.
This was a drug that I had never seen the likes of before. I was able to stop cocaine. I ran out of money. I stopped doing it. I realized this is a bad thing. I probably do this too much. I should stop. I got bored with ecstasy. K came and went. G sent me to the hospital. And then there was crystal. And I was not equipped to battle it, to stop it. It was something I hadn't felt before. And I don't mean felt like good, oh boy, that was great. It was, I was imprisoned. I was a slave to it.
Was it too out of control to work in a corporate job? Yeah. Was it too out of control to work in a nightclub? No. Was it too out of control to live in a bathhouse? No. Too out of control to eat Thanksgiving dinner with my parents? Yeah.
It kept me centered in the fact that I had been holding back on life way too much. I wasn't living it. I was just a spectator. This was my 15 minutes. I was the president of the incoming freshman class at Pig University. Pretty simple. Get high, get naked, get more.
When I wasn't working, then I was having sex. Bathhouse, bookstore, park, on the computer. Marathon sex.
Be up for days, out of it, watching porn, jerking off, out of the truck, fucking rough. When was the last time you slept? Little bits, and I'd be up, tweaking out, jittery. Pretty easy to hide. No one knew. Sketchy.
It just slowly saturated. Drama, craziness. It just took over.
Goes off weird ass ends. Huh? James Gardner got a facelift. Yeah, he's cool. He's maintaining.
Good drugs, pharmaceuticals. My grandmother would be dead. My sister had a baby.
Illness in the family, death of a pet, breakup, nothing mattered.
Lost a job. I gotta not think about this. My grandfather died. Took it in the bumper with me. Coping with the whole thing. Loaded. My boyfriend. I used them. Crystal. Beliefs. Stoned out. Nothing mattered. Nothing. Bathhouse. Knowing I had gonorrhea. Dealing hardens you real fast. Cynical, skeptical, non-trusting, cold, edgy. Didn't allow myself to come down for months. Intense, emotional. Slept a lot, eating a lot. Junk food, cookies, Little Debbie's, crying, depressed, hated life. Nothing could help you. Nobody's your friend anymore. Your best friend steal from you. Met him online, bottom, top him. He wanted me to come inside, so I did. The phones and the traffic and things getting out of control. Try having sex with a hot trick when people are pounding on your door, hey, can I get a quarter? Or something like that. Just blows it, ruins everything.
That was life. I'm a Christian.
Intense, huh? Just a minute. Let me put it again. Stop sharing. So, so that's the thing with crystal meth, and whatever you saw here, it's a thing that it might look to you like, something which is exaggerated, but it's really not. And this is what we see a lot in the clinics here, also at Sinai, and the issue of crystal meth addiction. So there are studies who actually shows that people who are getting addicted to crystal meth, 90% of them will go back to doing crystal meth. And this is a crazy thing. Like, it's so hard to get out of there. So that's why, unlike other things that we are doing, we are saying, okay, let's do harm reduction. That's fine. And I'll show you about it also in a minute. I feel, and it's not just a feeling, that this issue of crystal meth is something that you shouldn't go to right from the beginning. What's going on with my, I'm looking for my presentation again. Can you see my presentation now? Hello?
Yes.
Great. So having said that, we did a lot of nice things regarding like harm reduction. So first of all, during the 2018 parade in Israel, gay parade or the LGBT pride, what I created with friends was a table that was all over the city. And by the way, still now it's in like magnets on people's refrigerator, which was all about mixing and what is very dangerous mixing kind of drugs with the other kind of drugs. For example, GHB, which is kind of like in the heterosexual world, this is kind of like the rape drug. This is how you call it. But for gay men, usually you just use it as a sexual enhancer. And it's a very tricky drug because on the one hand, if you do it right, so eventually it works on the GABA receptors and it's a bit like alcohol, so to say, but the effect is it's very different. And the thing with GHB, for example, that it's a very tricky drug regarding that. If you do it right, kind of doing right, the day after you won't feel anything, won't be hangover, nothing. But if you are mixing it with specific things or taking a new dose very oftenly and not like separating them 2 hours apart or using more than 2 milliliters, it comes like a transparent, like water, actually, it looks like. So if you take too much or you mix it with the wrong things, this is one of the drugs that can actually kill you. And we see like once a year or 2 times a year, people who are getting killed just from using GHB or G, or it's called in the gay community, it's called Gina. And crystal meth, by the way, the name is Tina. And one of the major things that a lot of people know already that you can't mix is alcohol and GHB, 2 CNS depressants that if you use them both together, this is like a great recipe to end in the hospital, if you're lucky, by the way. So we see that a lot. A nice thing that I did also 2018, and since then it started, it's a project called Party Keepers. We did it together with the ambulance services of Israel. And this was all about, I felt that a lot of people who are having drugs, especially in parties, if their friend is overdosed right near them, they don't know what to do if he's either losing his consciousness, but other stuff also. So we kind of created a 4-hour course, which is all about like, how can you help your friend if he's in the middle of, if he's overdosing. And it's not about like learning how to do chest compressions or stuff, especially because we knew that the people who will help might be, on something themselves. So what we did is actually giving a very easy measures to do, which are actually saving life, like showing people how to put someone on recovery position. I don't know if you're familiar with it, you can take a look at it. But this is kind of like, because one of the biggest things, for example, in GHB is aspirations. This is like one of the causes of death. Or a lot of them are getting hypoglycemia, and sometimes this is all what they need, something sweet. And this can prevent them just from going to the hospital. I will try to do here, let's try again this, just a minute. Okay, I'll show it to you later because there is a small movie about that also. And having said that, we also did like a big presentations about like all harm reduction in the LGBT community, in the LGBT center. This was also 2018, and since then we keep on doing a lot of stuff. Now, one of the things that is challenging for me the most is actually talking with those kind of people. So those lectures I gave to the main officers of the police, for example, in Israel, and the one down was given to a psychiatrist, Ramat Chen. I don't know if you know it. It's a psychiatry place in the center. So I gave it to psychiatrists, and the main issue is, think about it. What happens if you are coming to the police as a physician and saying, okay, I know that you as a law enforcement people needs to say everything is like black and white, drugs are illegal. But in my perspective, as a physician who doesn't want to see his patients eventually end up in the hospital, maybe I should not do the same. Maybe I should say, okay, if you are doing drugs, tell me all about it, and let's see what can we do about it, and how can we prevent you from getting to the hospital, or worst case, die. So it creates usually an amazing talk also with law enforcement kind of like crews, because, think about it. In one of the part of my lectures, for example, is talking about MDMA, or ecstasy, actually, pills of ecstasy. Each pill of ecstasy contains totally different materials, and sometimes you don't know what's inside. So some of it is MDMA, but a lot of other shit is going on in these pills. And one of the things I'm saying, just to provocate a bit in those lectures, is that I'm telling my patients, okay, if you found a good ecstasy pill, buy 5 like those, because you will know that this one didn't do any bad to you, like anything which will harm you eventually, while buying it from a dealer in the middle of a party, this is one hell of a chance that you're taking on your life. And then you can just imagine which kind of a talk it's creating with those kind of people who are all about law enforcement, when they might ask me, okay, but you might give, make it legit to use drugs, and it creates a very interesting talk. So this is like one of the things that I'm trying to do.
Sorry, I have another question.
Yes.
Sorry, can you repeat? So from my understanding, in New York City, I grew up there, but just like you can basically, if you're in trouble because a friend is overdosing or something, you can call the hospital or 911 without fear of legal repercussions. And I just want to check what the protocol is here in Israel, because in the emergency room, we've seen some people that were sort of getting over an overdose, and it didn't seem like there was any police involvement. So
yeah, right. So it's quite the same.
I just want to know so that I could it would be nice to be able to tell people, basically, if you're worried about a friend, or if you're worried about yourself, have no fear in calling an ambulance.
Right. So first of all, so it's exactly like in New York. In Israel, if you use drugs and you need some medical attention, of course, your secrecy and is privileged. Like, it's not something that is going to somewhere to the police or to the other authorities. And this is, like everything in your file. If you are HIV positive, if you are, just having other issues or mental issues, it's exactly the same. So, and by the way, this is what I'm telling always the police also. Like, in a perfect world, where you can see everything in black and white, you can totally enforce people from using drugs, and then it won't happen. But eventually, the police is not looking for the specific end user. They're usually looking for the people who are actually, giving those drugs they are dealing, and not like just end users. By the way, what I wanted to say is, it reminds me that don't make the mistake thinking that those people using crystal meth, for example, or all those people using GHB are kind of like low socioeconomic people who are coming from low socioeconomical background, all kind of those things, I can tell you, lawyers, physicians, everyone is taking part in it. Sometimes, and it's not an issue of a specific socioeconomical background. So this is something you should understand. And I saw already also in Israel, but for sure here, people who lost their very, very precious and very, high level work just because of drug using, and they couldn't stop it. So at the beginning it was just weekends, they were starting like looking for the weekends and having the great job during the week, but they were always waiting for the weekend to, kind of like get it. It's part of like, I think like it's also part of like living in the Western world nowadays where you're so, all about achieving stuff. So this is kind of like your way for relief. But then when your relief becomes a problem, that's where all your problems begin. So when you start using in the middle of the week, and usually those people who are doing that, it's really hard for them to call it a problem. And this is kind of like a problem that you should know about, because most of them will have this, rationalization for what they are doing, but eventually they will need their help. When they ask for help, usually it's just when they are getting to the extremes or the end point. Another questions before I'm continuing? How much time do we have? There are so many things to talk, and yeah, we won't do it all. Okay, so PrEP. Let's talk about PrEP. Who's the volunteer to tell me what PrEP is all about?
Okay. PrEP is for
before.
Yeah.
Exposure.
Yeah. Wait. Hold on. Mimi's got it. I'm too shy.
So it's a medication that you can give for patients who think that they may be exposed to HIV, and so you can basically, if someone has a partner that is HIV positive, sometimes those are people that take PrEP, and that's basically.
So when you are talking about being exposed, you mean like they had sex and they think they were exposed?
No, that's post-exposure. I'm saying pre-exposure. So it's basically if you think you're going to have sex with someone who is or may be HIV positive, you take PrEP. So if your like girlfriend, boyfriend, whatever, has HIV, and you know that you're having sex with them, you get a prescription for this.
Okay, it's great. What you said now, it's great because it will lead me next to the next topic I wanted to talk about. So eventually, PrEP is pre-exposure prophylaxis for HIV. It started in the first studies about it were being done in 2010, and there was the IPREX and the PROUD study and some other studies that showed actually that if you take Truvada, which is kind of like an antiretroviral drug that used to be taken by HIV patients for long years, if you take it on a daily basis and you are in, kind of like a risk for exposure to HIV because you are having a condomless sex, because you are using drugs and don't remember sometimes what happened, or etc. If you take it on a daily basis, do you know if you will take it on a daily basis, what's the percentage of prevention?
It works very, very well.
Very well, 70%, very well, 80%.
Like over 95%, I think.
Okay. So the numbers by the CDC now, it's 99%. Right. So if you take this pill on a daily basis, and you are being in a danger of exposure of because of your sexual behavior to HIV, it will prevent it in 99%. There are two kinds of drugs in the market, Truvada and Descovy. Descovy is the next generation. Each one of them has its pros and cons. Now, pre-exposure prophylaxis, according to the CDC, 1.1 million people actually needs to get PrEP in the US. Out of them, just 150,000 people are actually getting PrEP here, you know, in my clinic here, and also like in Tel Aviv. So in Tel Aviv, PrEP was introduced in 2017. In the New York was the first place where PrEP was introduced, and this was like 2012. And we saw a crazy decrease in numbers of new infections in specific populations in New York, in New York City. And every year it's just going down and down just because of PrEP. Now, having said that, you might imagine what PrEP would not prevent and what it might increase, which is?
Other types of STDs?
Right, other sexual transmitted infections. And this is a major issue. So while we are preventing HIV from happening, we are always asking ourselves what's going on if people are, you know, not using condoms anymore and have higher rates of STIs. By the way, officially, of course, we are saying that PrEP is not a substitute for condom because it does not prevent other STIs, but it's an addition. Practically, most of the people do not do both. Some of them do. But yeah, this is a major issue that we are trying to deal with, and we do see a crazy increase also by the CDC in the last few years, and also in Israel in STIs among MSM, men who have sex with men mostly. And this is kind of like a big thing that we are talking about. Now,
yeah. I'm not sure which study exactly this was. They tried to kind of disentangle this issue a little bit. I mean, sort of seeing the causality correlation thing. Right. And from what I understand, it seems to be that the people that are actually taking the PrEP are not those people that are necessarily transmitting the other STIs. It's more of like a diffusion of responsibility issue within the community at large of like, okay, now we know people are kind of being safer, so we as a whole don't need to use condoms. The people taking PrEP are people that are concerned about health generally. I don't know, what is that like what you've heard? I haven't personally read the article, so this is more something I heard about.
That's actually a great comment. So what happened is, especially at the beginning of PrEP, the PrEP era, yeah, there was a lot of debate. Is there a really increase in STIs just because of PrEP, or do people just screen more? Because in order to get your PrEP, you have to do an STI screening every 3 months. So you do it more, so you discover more, right? That's what makes sense. But then there are a lot of studies that has been done about that. I'm writing one myself now also. I will tell you all about it in a few. But the thing is that the interesting thing to see is how the population that is taking PrEP was changing during the time. So right at the beginning of PrEP, the people who actually took PrEP were the people who already didn't use condoms. But then it came to the point that during the years, more and more people who are sort of say good boys, kind of, who didn't practice condomless sex, were doing that much, much more. And then if we look at it chronologically, also when we look at the studies, we can see that, yeah, at the beginning, that might be just, you know, a bias because of extra screening. But when you look at it today, when so many people are using PrEP, also those who are taking their condoms off just because of PrEP, we do see a real a real increase in STIs, and this is important thing to understand. So eventually, if you look at all the studies, there are to both sides, by the way, but if you look at it all together and you review it all, there is an increase. And by the way, it doesn't matter if it's because of extra screening. It is what it is, yeah? If you have more, so you have to kind of like address this issue. But this is eventually that. Did that answer your question, or you meant something else?
Good.
Okay. So I want to go, I will skip this vaccination stuff. I will tell, if we'll have some stuff, I'll tell you about it. But just because when you commented on the issue of being on PrEP with a partner who has HIV, can you, so do you think that a patient who is HIV discordant couple, what we spoke before, one is HIV positive, one is HIV negative, do you think that the partner who is HIV negative actually needs to use PrEP no matter what?
Don't you have the answer on your slide?
But I'm asking you.
No, if your CD4 count is high enough and your titers are low enough, you don't need to worry too much.
So it's not about worrying too much. And by the way, it's not about CD4 count, but more about your viral load. Yeah. So there was a great study that was published and started like 2015, 16. And then like the second study was in 2018, both of them called the partner studies, partner 1 and partner 2. And this created an amazing concept, which is all about U equals U. Undetectable equals untransmissible, which means that if you are undetectable, you cannot actually transmit your virus, even if you'll make the biggest efforts you can. As long as you're undetectable, you cannot transmit HIV, not by sex, by sexual contact. The study was never about like blood products and stuff. It was all about sexual intercourse. And when they did this study, the partner study, so the thing is that, you know, they checked for they counted more than 70, oh, what's going on here? They counted more than 77,000 sexual intercourses. And out of those 77,000 sexual intercourses with more than 1,500 couples that were checked, discordant couples, how many did have HIV? All of them were doing practically condomless sex between themselves. So how many do you think out of like 77,000 sexual intercourses? Someone want to guess? So the number is 0. 0. This is a number we don't see in medicine. If you think about it, you almost never see 0. And they just came to the conclusion in this great study that the odds are 0. And that's why we are safe enough to say undetectable equals untransmissible. And this is something which, you know, this is one of my biggest pleasures, is to go to this couple who are together for 30 years, and it happens a lot, and they are still having sex after 30 years, one with condom, just because one of them is HIV positive, and telling them why, and then like telling them about this study and everything. And you might think, how much does it change their life knowing that they are not of a harm to their partner? Having said all of that, you can never, this is all about partners. So if you are having a sexual intercourse with just like someone you just met on Grindr, or, you know, one of the sites for just like getting men for a hookup, you can never, you know, you can never count on it that he's undetectable, right? So what? So he said he's undetectable. Can you say, it's all about being, you know, it's all about couples, and this is kind of like the thing, and not, you know, saying, okay, I'm undetectable, no problem, so I can hook up with whoever I want. Okay. So did you have a lecture about HIV? Because we won't have time for all of that. Yeah?
Yes.
Okay, great. So I won't tell a lot about HIV because I'm sure you had a great lectures in the past. This is a bit of a numbers from from the US, actually by the CDC, and those are the numbers in Israel and in new infections in 2017, 18, and 19. And you can see that in MSM, there is a small but a consistent decrease in the numbers of new infections among men who have sex with men. And this is since PrEP started. So we do see the beginning of, decrease in Israel. We still have a work to do. But I wanted to concentrate, again, like we're talking about concepts because there are so many things to do. Transgender care, I hope we'll get to that. But what I wanted to tell you about was, okay, we talked about STIs, right? So let me pick, no, I won't do that. So I won't be shaming anyone. So sexual transmitted infections. As a gay man who's on PrEP, if I want to screen myself for chlamydia or gonorrhea, how should I do that? I'm asymptomatic now. And I want to just renew my PrEP or get my refill for PrEP. Which test should I do to discover my chlamydia or gonorrhea? No answers?
Nucleic acid amplification test.
Okay, so I didn't talk about the way you do that, but you are right. This is like kind of a PCR or not, right? But how do I check it? Is it blood? Is it urine? Is it something else?
Urine, I thought.
Right, who said urine? Talia? Oh, Taylor?
Taylor.
Okay, so Taylor, okay, urine. And as a gay man, is urine enough? For chlamydia?
Well, that was from Mimi. Anal.
Who said anal? Thanks for not being so anal and saying anal. Okay, and what else? So
oral.
Anal and oral, right? So what you should remember, and this is kind of like a big issue in MSM and in bisexuals and also transgender people, is that you have to check it for 3-site testing. How much do you think you will miss if you will do just urine test for someone who is sexually active and he is MSM? In percentage, if you just do urine test, how much will you miss? No answer. So I'll tell you how much do you miss. For sure, you're missing more than 85 or 90% of the positive results. So urine test for asymptomatic patients is almost a waste of money and time. And this is something you should understand. Chlamydia and gonorrhea are actually being transmitted according to the site that you were, sexually active in. And if you are having a receptive anal sex, so the rectal area is your area to go. And if you had an oral sex, your pharynx is the one you should check. And this was a crazy story in Israel because in 2017, when PrEP was introduced to Israel, the HMOs, Clalit and Maccabi, etc., did not check for 3 sites for gay men. And they checked only for urine. And of course, what happened is a vicious circle where people keep on doing, their urine test. It was always negative. They still gone with, chlamydia or gonorrhea, which were asymptomatic. I'm sure you know that most of the chlamydia trachomatis and gonorrhea are usually asymptomatic, right? Most of the infections are asymptomatic. And what happened is that they kept on doing urine tests, and there was a vicious circle in Israel of gay men who are having the test their physician told them this is what you need. They thought they are okay, but they kept on transmitting chlamydia and gonorrhea. So what we did, and this was one of my biggest projects while I was doing infectious diseases in Ichilov, actually. So I got 750 tests by a specific company called Gene Expert. They are doing the TB test also, but they are having a great platform for CT and GC, like chlamydia, trachomatis, and gonorrhea. And we just told patients, okay, if you are men who have sex with men, and if you are asymptomatic, and if you had condomless sex in the last 3 months, come on and check yourself. This would be a great way for you to check 3 sites because you can't do it in your HMO. And this would be a great way for us to see what's going on in Israel, right? And how much do we actually miss? So we recruited 70 people on PrEP. We recruited 60 people who are HIV positive, and we took kind of a control group who are saying at least that they are using condoms all the time. And they're all got 3-site testing, like 3 tests. One urine test, another is pharyngeal test, and the other was rectal swab. They were all doing it by themselves. It was a self-swabbing, okay? And these were the results. So out of 210 people eventually that we checked, 48% from the PrEP group were positive for either chlamydia or gonorrhea. So half of those were positive, while only 2 people out of all the study of 2010 people had a urine positive test. And all the others had it on other sites, on either rectal or pharyngeal. And this is like an important concept that was very important for me to address here in this lecture, because you should understand and be kind of like the ambassadors of this thing, is that urine tests are just not enough at all. And this is kind of like by the CDC guidelines also and everything. But this is something that physicians and primary care providers tend to forget while testing for sexually transmitted infections. And that's why we did this study. Since then, Israel and the HMOs in Israel are doing 3-site testing. This study was a big part of it also. But it was a big battle with the HMOs to make it happen. And I won't keep talking about other stuff because we actually asked people about their drug use and other stuff, and it was very, very interesting. So hopefully in the next few months, it's going to be published in a good place. So you can follow me up and I will send it to you. We just submitted it. So that's an interesting thing also. Some questions regarding that?
Yeah. Could you save money by asking, so does your sexual history include anal intercourse? And then if they say no, you don't need to test that area. And wouldn't this apply to any, like any couple?
Yeah, I mean, there are a lot of hetero women that are having anal intercourse, I think is what Rob's
right.
getting at.
So both comments are great. I'll start with women. So one of the things that is, so officially by the CDC, it's not a common thing for women having a rectal swab, but we do see for sure, again, like I said, those kind of infections are site specific. And, you know, it's all a matter of what you're doing in your sex, and that's it. This is how it should be addressed. But to your question, this is part of not wanting to disclose people, or it's, you know, some physicians are not into, you know, starting asking, okay, so were you like the passive, the active, the, you know, whatever. So the CDC actually says, check for 3 sites. That's it. Don't ask too many questions. People sometimes lie, people sometimes not. You shouldn't count on people's response when you check for STIs. So just check it on 3 sites, okay?
Sorry, can someone mute? So in your personal experience, how do you think is the best way to ask about sexual practice among people, just in terms of like,
Right.
after you interview someone, you're like, oh, are you sexually active? Yes. Okay. So can you tell me a little bit about your partners? And they say, okay, yeah, like men and women or something. And then do you tend to ask, like, do you have both receptive and penetrative intercourse? Or like, is that just a question you skip over?
Okay, great. So the thing is that first of all, different people are different, meaning that it depends who, and you get this feeling and like intuition when you are doing it more and more, who are the people who will answer it like really easily and it's not an issue for them, and who are the ones who are not. Now, having said that, you should always remember, and this is like kind of a thing that I learned during the years, and this is not just about LGBT medicine, but generally, if you make something embarrassing, people will see it when you are asking it them. And if you are just asking it as another question, out of like bunch of questions, and this is not an issue for you, usually it won't be an issue for them also answering it, because they actually understand that it has a meaning. It's not just for your gossip. And sometimes if you feel someone is not so comfortable talking about it, so just explain him why you are asking it. Why is it important? Why knowing about like, your sexual behavior, how does it change the way you will, get some tests for them or not? And this is an important issue. So whenever you bring it to the medical field, it shouldn't be an issue. But again, it's very, very individual. So you might not ask it someone who is really closeted now, did you have a receptive anal sex, or were you the passive on sex? If it's not really necessary and you feel it brings him to the position where it feels not comfortable answering it, okay?
Okay, thank you.
Great. So I won't go through HIV too much. By the way, one of the important things, I don't know if they told you in the HIV lecture that you have. So one of the major things we are doing, first of all, we are stopping using the word HIV carrier, no HIV carriers anymore, but we are using people living with HIV, okay? This is kind of like an important concept, because being a carrier kind of like bring a negative connotation to HIV, kind of like being a carrier of something, but actually people living with HIV, this is what we say, this is how it goes in all the lectures today, and this is how you should address to it also. And one of the major things that we are trying to achieve today by the World Health Organization and the UNAIDS and here in New York, and also Israel is part of like this program, is the 90-90-90 program, which is all about eliminating HIV. So we want 90% of the people to be HIV, to know their status. We want out of those 90% who knows their status to be virally suppressed, and out of those being treated, and out of those being treated, 90% should be undetectable. And this is kind of a achievable goal to 2025. Every year it depends, and sometimes they are changing the year. And it will become probably again like 2030 or something, but this is kind of like the concept. And today we have the fourth 90, which even a lot of HIV physicians might not be familiar with, but is aging with HIV and taking care of your comorbidities. So of course, every HIV patient, physician knows about the importance of taking care of comorbidities, diabetes, hypertension, etc. But this is kind of like the 940, the fourth 90, sorry. Okay, great. So let's a bit go over transgender care. How much time do we have? Oh, not a lot. So I'll just talk
I
about it.
think we're running out a little bit. A lot of
Okay.
us need to leave at 4, unfortunately.
Okay, so yeah, so regarding transgender care, I will just say that, you know, first of all, if you want the best article to read about, very easy to understand, and this is my message, so we won't get into it too much today. So there is a great article was published in December in New England Journal of Medicine by Joshua Safer. He is the head of the program here, the transgender medicine program. And he's kind of like #1 in all the area of transgender medicine. And he kind of made it very easy for people who have no idea about what are transgenders, what is all this, like how do you start reading transgenders, what are the major issues. This is like a very short article that says it all, and you should read it. And that would like everything that I wanted to talk about is actually in this article. So just do it. I really suggest you. I think you will get much smarter after reading it. Okay. So yeah, but transgender medicine generally involves, you know, either the endocrinology and the hormonal therapy, plastic surgery, mental health, urology, gynecology. And here at Mount Sinai, there is the Center for Transgender Medicine Services. And this is today, I think it's the biggest center in the world, actually, in the numbers of surgeries they are doing. Someone just mentioned at the beginning of the lecture, Dr. Ting, and so there are few physicians here who are very, very famous in transgender medicine surgeries and stuff. And yeah, it's a great program here. And for me, it's kind of a privilege being here and study every day more about this area. But unfortunately, we won't have much time. And I wanted to talk also about the world of non-binaries, which is a totally another concept, but we won't get to it just because we don't have time also. But I would suggest you reading about it also a bit. Non-binaries, which are kind of like people who don't want to, you know, say them that they are either he or she, and they feel that they are either neutral in their sex, or they're bigender, or they have a third gender. And this is like a major issue here in New York. I see it more and more. And I am sure that in Tel Aviv, it's going to be bigger and bigger also. It is happening already, but you should know about that. So we'll skip that. And this is an important thing. So we just started. So I'm part of the LGBT Medical Society in Israel. And just today, this is an article from today. So I just put it in just now. So it's a group of students, of medical students, who actually wanted to know, know more about LGBT medicine, and they wanted to put some, more content of LGBT medicine to the, while studying medicine. So they started a new thing with a lot of new, like they're doing lectures and education and community involvement. And if you want to take part in that, you should just write this email. And they will answer, and you can get into it and know more about LGBT medicine. That's really, really cool. They just started it, and I think it's going to be amazing. So I would suggest you doing that. And the last thing is, I will show you in our last minute and a half, a movie that's called the LGBT or the Proud Revolution in Israel. Was done by Gal Ochofsky. I don't know if you know him. He's like a producer, he's kind of a producer and makes all kind of films in Israel. And this is a movie that was done about LGBT, and this is my part. This was my part there, talking about LGBT medicine. So we'll end with that, and then if you have last questions, and that's it, we're gone. Just a minute. Can you see my screen now, by the way?
Yes.
Great. So you see the Vimeo, right? Okay. So the English, there are English subtitles. And let's go.
אבק. להיות מחוץ לארון.
Do you hear it? Can you hear it before I'm starting?
Yes.
Okay.
המאבק שלנו לנראות מתרחש בכל מקום. אולי קשה להאמין, אבל לפני עשור, גם בבית החולים איכילוב בלב תל אביב, היה רק רופא בכיר אחד שכולם ידעו שהוא מחוץ לארון. גם במערכת הבריאות המלאה בדוקטורים ודוקטוריות, היו הרבה דעות קדומות, פחד וחוסר ידע. אתה מכין את היד ללחיצה, כי אתה רופא. ברור, בסדר גמור. החלטת שאתה תהיה רופא שמתמחה ברפואת להט"ב, שזו החלטה יחסית נועזת.
אתה תראה אותי אחראי במיון לפעמים, כשהומואים מגיעים עם כל מיני בעיות. אתה תראה אותי במרפאת HIV, אתה תראה אותי במרפאת גן מאיר, אבל אתה גם תראה אותי לפעמים במסיבות. ואני נמצא בכל מקום, ובהתחלה זה קצת יצר מצב מאוד מאוד לא נוח, עם מטופלים גם. ואני חושב שהיום, שנה וחצי, שנתיים אחרי, אני במקום שאני מספיק שלם עם עצמי כדי להבין...
כשניגש אליך במסיבה, מישהו אומר לך, דוקטור, תציל אותי, ואתה לא נבהל מזה.
הוא יכול לקבל חיבוק ונשיקה על הלחי, אנחנו ממשיכים הלאה, ויכול להיות ש3 ימים אחרי אני אראה אותו בהקשרים רפואיים, והכל בסדר.
היה יותר קל להגיד להורים שלך שאתה הומו בגלל שאתה רופא?
תמיד כשאתה יוצא מהארון, אתה חושב על ה-worst case scenario, ואני חושב שההורים שלי היו מדהימים בקטע הזה, ואחרי תקופה קלה של הסתגלות, כן, בסופו של דבר הם קיבלו את זה די מהר, אבל ברור שהחלק הזה של להיות רופא, הרבה פעמים הוא מחפה על דברים אחרים, כי זה משהו שאפשר לדבר עליו עם המשפחה, יש את הבן הרופא.
הוא יכול להביא כדורים. היום הנראות של רופאות, רופאים ואנשי צוות להט"בים במסדרונות איכילוב, אחת המערכות הציבוריות הגדולות במדינה, היא מובנת מאליה.
אם פעם הייתי קצת יותר אולי חושש או מפחד למצב את עצמי כרופא ההומו שמטפל בהומואים, היום מבחינתי אני רואה בזה
אתה רוצה להיות שכולם ידעו שאתה הרופא ההומו שמטפל בהומואים.
אתה יודע, לא... אל תגזר.
איך זה יכול להיות שכל ה...
Okay, so I hope someone was left here because it seems like everyone is already in view. Is someone here already or?
We're still here.
Great, so...
We're still here.
Great. So that's it. That is my either my professional Facebook page or my email if you want to ask me some questions. And I hope you kind of like got at least a bit of what I'm doing and what is all about LGBT medicine. And there's so many topics to talk about more, but it was just like, you know, a taste of that. And I hope you enjoyed. And that's it, I think. Any last questions?
I have a last question. Sorry. I'll speak for me and Mimi. So we're the heads of the queer student group for Sackler for the American program, and we are wondering if there would be any possibility of us getting in contact with you and being able to set up sort of the same lecture for the other members of our group, because this is just our hospital group.
So yeah, so first of all, this is why I asked Lior also wanted me to bring this lecture on, that it will be recorded. So all we did today is recorded actually, and it will be, I hope you will publish it somehow. And yeah, just like write me on an email. I'm kind of like very, very busy these days, but we will try to figure out. I think it's very important and it's kind of like, a major issue to talk about. So
yeah, and I'm sure members of our club would love to hear it.
Okay, so no problem, and you know, it's important for me also to know who is the audience, just to make the adaptations. Okay.
Yeah. Thank you.
Sure.
Thank you.
Thank you very much. It was a pleasure, and keep on doing what you're doing. It sounds really good. Bye-bye.